Hello friends, today we are going to discuss about awake craniotomy and let's try to understand this highly complex neurosurgical procedure. So awake craniotomies are used when the tumors in the brain are located very close to highly functional areas like our speech area or motor areas which are responsible for our hand and leg movements. And if we perform these procedures in these tumors in complete general anesthesia, then there is a risk of damage to these important brain areas and these patients might wake up with neurodeficits like weakness of one side, that is called as hemiparesis, or speech impairment. So to avoid this problem of neurological deficits, awake craniotomy has become gold standard in neurosurgical practices. So during awake craniotomy, the patient is kept conscious and awake throughout the procedure. Scalp block is given, that means only the scalp part of the head is made numb by anesthetist, and then the craniotomy is carried out. After opening the skull, the various areas of the brain which are exposed are mapped using bipolar stimulation, that is by giving small currents using an instrument and asking the patient to actually perform some tasks like counting numbers or identifying objects or making calculations, and then these areas are identified. So once we identify these areas, the tumor is removed simultaneously while asking the patient to continuously perform such language and motor tasks like moving the hands or moving his face or performing calculations, identifying objects, etc. During surgery, if we reach very close to these areas, then we can either stop the procedure or we can move to some other areas, and so that the patient should not develop any major problem. Thus, using awake craniotomy, the golden concept of maximum safe resection can be achieved, and the patients usually do not wake up with dense deficits after awake craniotomies. So awake craniotomies, as you understood, requires a close cooperation and understanding between an educated patient, the neurosurgeon, the anesthetist, electrophysiologist, and it is a complete teamwork. So recently we operated a similar patient who was a teacher by profession, highly educated person, and had a left dominant temporoparietal region tumor. So this tumor was very close to the language area, which is important for reception of the speech, that is in medical language called as Wernicke's area. Being a teacher, the patient was highly educated and we could counsel him well with the help of a speech therapist, and he was explained the complete procedure and he understood, and then he agreed for awake craniotomy. The crucial language areas responsible for the speech reception were painstakingly identified by stimulating the areas of the brain with a bipolar stimulator, and at the same time asking the patient to perform the tasks of language understanding, that is naming of objects, naming of pictures, and performing calculations.
राजाच्या डोक्यावर काय घालतो?
मुकुट.
भारताचे पंतप्रधान कोण आहेत?
नरेंद्र मोदी.
राष्ट्रीय पक्षाचे नाव काय?
मूड. पिक्चर.
हा कुठला कलर आहे?
ब्लू. This is a blue.
Yes.
This is a braid.
Yes.
This is a telephone.
Yes.
This is a comb.
Yes.
This is a coral.
Yes.
This is a
So in this
watch.
part,
Yes.
we can see that we are checking responses from the patient and he is giving
Yes.
correct answers and identifying the objects correctly.
Yes.
So these are language
Yes.
negative areas.
Yes.
So the areas of the brain where the patient consistently made mistakes were identified as positive areas of the language. That means if we damage these areas, the patient will have a permanent speech deficit.
is a black.
राष्ट्रीय पक्षाचे नाव काय? राष्ट्रीय पक्षाचे नाव काय? राष्ट्रीय पक्षाचे नाव काय?
More.
भारताचे पंतप्रधान कोण आहेत?
Our Narendra Modi.
So in this video now we can see that he is actually making mistakes in identifying objects and also mistakes in pronunciation.
कोण आहेत?
At one place we can observe that he is unable to speak for few seconds, that is a speech arrest. So mistakes made by him are like Narendra Majju instead of Modi, or there is a delay in the response in giving answers. So these are language positive areas which are marked with the letter P.
Amba.
So once we identified these areas of language reception, that is Wernicke's area, the task was simple. Now we entered the tumor through the language negative areas where the patient did not commit any mistake, and then we removed the tumor. During removal of the tumor also, the continuous monitoring of language function was carried out by talking to the patient continuously and repeatedly asking him to perform the speech task. Maximum possible safe resection of the tumor was done, and at the end of the procedure, the patient's language function was intact. Despite of this, on third post-operative day, the patient had mild difficulty in calculating simple mathematical problems, as well as he had difficulty in identifying the routine objects, which is called as anomia. So this is typically observed due to post-operative edema, because we go there and handle the brain and that reacts to tumor removal by some edema. Typically lasts for around 2 to 3 weeks and it subsides with the help of post-operative steroids. Hence, after 2 to 3 weeks, this patient had almost no difficulty in language function, and last follow-up he was not having any neurological deficit. So this uphill task was possible only because of educated patient, a complete and dedicated teamwork, and the high-end technology available at Jupiter Hospital.